Thanks for having me today, and I'm standing up here with my name on that, but actually this is a team effort, and that's why we've got Jess here today, who's our Colic Clinic Coordinator and deserves just as much of the limelight really for the efforts that have gone in over the years setting up these clinics. And I'm really speaking on behalf of a large group of people at Barwon and Colac who've done so well over the last few years. And I hope it's a helpful experience to hear about because it brings together a lot of the themes that have been discussed. Here's a little snapshot of how bad it is in paediatrics. We're the same as everyone else. We can't provide the services that people need, particularly in paediatric outpatient care. And it's sort of got into this cycle where we're now in weekly media addressing this, and Facebook and Channel 9 and all the people are really concerned, correctly, because we aren't meeting the goals that we ourselves would set for helping these patients. So we need new models. And we had a very unoriginal dream that sort of pulls together a lot of the themes and the discussions that have happened at this conference, really, which is that we wanted to think about a new model, and we wanted to start by building a totally equitable service. Wow. That was really bedded down in multidisciplinary care and both used it and expected to share care out into the community with the GPs. And we wanted to use this clinic to act as a way of drawing in the great local support services and attracting really good local staff. And then we wanted to use intake assessments as a way of doing research within a clinical setting from the get-go, and to help guide care and help the patient journey be more efficient. And at the start of 2022, it was just a dream. And then we had what I'm calling our Totoro moment. So for those of you unfamiliar with the amazing film, My Neighbour Totoro, in the film, two girls are given a little packet of seeds by the forest spirit, Totoro, and they go off to the garden and they plant them and they await the results. And that night they have a very vivid dream that Totoro visits them and he brings his compatriots and they all gather at the garden bed and they perform a sort of growing spell on the garden. And then right before their eyes, this huge tree just explodes out of the ground into an instant, gigantic, established forest. The dream ends. And when the girls come out to the garden the next day, there isn't a forest, of course. But there is these tiny seedlings popping up. And everyone's ecstatic because, of course, the growing spell has worked. You can see what the forest will be when you see the seedlings. So Barwon Health gave us our first packet of seeds. And it was after we'd had our little planning session in 2022, and they funded a pilot to start something called Branches, which is the name for our paediatric outpatient clinic. And of course, we were like, right, let's do everything. But we had to try and focus and give ourselves, I guess, enough to do without overwhelming ourselves. So firstly, we wanted to do really detailed intake assessments for all patients that acted to set family expectations, set clinician expectations, and actually help them communicate with us before we'd even seen them. We also worked really hard to get fantastic people. Several of the fantastic people are here, and one of them's coming up on the stage with me. And it has been the difference between success and failure. We also wanted to find interested local GPs to actually work in the clinic with us in the hope that they'd develop high-level skills and then they would go out into the community and lead their colleagues. So first we had intake assessments. A few people have mentioned REDCap. We collect them in REDCap, which is a kind of data system which we use at Barwon Health. And it captures key information which we consider important, but it's really about pulling up all the carpets and looking under them, because lots of these kids are very complicated. They've been looked after by many different people, have had a lot of different assessments, and it's such a waste of effort when someone arrives at a clinic for the first time and that's the first time any of those threads have been tried to be pulled together. So in Colac, Jess works really hard to dig up all those things, pull them together and present them before we've even seen the patient. And then that goes into our EMR. We also ask the families directly, what do you want to get out of this appointment with us? And their goals of care actually inform what we do next. And we're developing a more sophisticated allied health triage approach, and we're going to have increasing sort of skill and development of that job to the allied health navigators in both clinics to get this process going and to connect people with services while they're waiting. And then we went and found the right people. So we had a very big team because we wanted to have the right people and enough of them at the right times. And we actually put the majority of our resources into our clinic coordinators and our social workers. Those two things, those two roles are more important than anything that any of my craft group or the GPs or anybody else does in caring for children with complex neurodevelopmental conditions in particular. And we have multidisciplinary case discussion that occurs before the clinic. And we also, I think, do a really good job of working the floor, right? So when the clinic room is full of patients waiting, people are out and about collecting information, getting people to sign forms, trying to follow up and make sure, have you done that? Why haven't you done that? Did Child Protection actually act, since we last spoke? And making sure that you've got those things covered off. And I feel like the waiting room is actually where we realise the value of the clinics a lot of the time. And then we went and found really good GPs and put them in, and we called them VMOs. So they're on long contracts. They're VMOs, treated the same way from a conditions perspective as the paediatricians who are visiting the clinic. Now, obviously at the start, they need a lot of support and supervision because they're doing quite specialised help for kids. But in return, we're giving that to them, and we expect that over their journey with us, they develop quite a lot of considerable independent skill that they will take back out into the community and act as the phone a friend for their compatriots and allow a kind of community of practice that isn't wholly dependent on this one clinic to spring up. A series of little nodes, seedlings. And we also wanted to really engage properly with GPs who are in the community only. And this was about imagining our own version of what shared care looked like, and the ultimate aim of shared care being to reduce the number of paediatric appointments in the clinic by having better planning and proper transfer of responsibility, but perhaps most importantly, never removing the support to the GPs. So after a patient is discharged from our clinic, those GPs in our region are able to contact our clinic at any time and get help and advice about the management of that patient. And if we agree that it's needed, they can refer the patient back in fairly efficiently. I'm not going to go into this. Anybody who wants to know the nuts and bolts of funding a model like this, they're welcome to find me. Each service probably needs to adapt it to its own various funding constraints. But I'm here to tell you that there is capacity and I guess the possibility within the NWOW system in particular for developing multidisciplinary clinics that really respect the work that all the professions do in caring for patients. But what it leads to is a clinic that never sleeps. So when GPs or patients need something, someone is almost always there. This is a mud map of Geelong, and I haven't included absolutely everybody in it, and the Colac Clinic looks very similar in that there's always a clinic representative available, which is really helpful for patients. They feel like you're there for them in a way that other clinics don't always feel like. So what worked in Geelong? We had great engagement and attendance. We worked really hard to get contact systems, ensure families were aware of appointments, and those initial intake appointments, I think, act as a kind of a handshake or a welcoming gesture to the clinic. It says, we're interested in you, we want you to come and see us, and that's why we convert it really well to face-to-face appointments. And we've actually, by having a really quite firm plan for shared care, we've been able to have quite high discharge rates from the absolute start in this clinic. I didn't know what they would be. We didn't have something to compare to. There was no paediatric outpatient clinic in Geelong. So I don't know if this is good or bad, but I'm happy that we've been able to achieve it. We've also been measuring patient-reported experience measures from the get-go, and we developed a series of questions based on the ABS and the Australian Hospital Patient Experience question sets. And you can actually, there is a live public dashboard with our results, which anybody can look at any time to see how we're going in the eyes of our patient group. And they don't see all the detailed part of the data, but they see a series of graphs that tell us and them whether we're being valuable for people. And if you look at our results, they've been universally positive. I'm not naive. I know I'm not capturing everybody. There's probably a lot of very disappointed people who don't bother filling in the survey. But when we drill down and look at why people are happy, it's so reassuring. They like person-centred care. They like friendly professional staff. You know, they think it's thorough and friendly. And all those things we really want, paediatric services, these are the watchwords for us always. We always want to deliver this for our patients. And one of the benefits which I did mention, and I'm not going to go into this, but we've got some data in the Bowen Health Research Day next week, but we've been able to put in place from the get-go quality improvement and research, which we're really proud of. One of our trainees, Dr. Lisa Galvin, surveyed our first 100 patients diagnosed with ADHD, and she was able to find that over half of those kids were able to be discharged to shared care within 1 year. And I know that the previous number before this clinic started was 0%, because we did not have a shared care approach to ADHD. So making model changes, being able to rapidly measure them and see them and then feed them back has been one of the great joys of having this clinic going, and it's great to be able to share all these data with everybody. And I think it's really hopeful for our wider effort of generalising the care of something like ADHD, which has been mentioned a couple of times in the adult space as well for GPs. But of course there's problems. Demand's very high. The black line is the number of people waiting, and the blue line is the number of referrals we got. And we've been going at 135 per month since the clinic opened. That was with zero advertising. No one has ever been told about this clinic. And it's just, yeah, in retrospect, it's pretty funny because the director was asked by the finance team when we were developing it, did we think anybody would come? And obviously the waiting list is blown out as you'd expect. However, we were lucky enough to get an expansion in April this year, and we're flattening the curve. And I think with one more expansion, we're probably going to be at the point where we can actually deliver everything that the Geelong area needs in a sustainable way and get our waiting list under control. Which brings me to the success in Colac, because we felt we were onto something and we wanted to try it in a rural setting where we had even more control, but perhaps even more difficulty. So it's over to Jess to tell you all about that.
So we felt we were onto something with our overall clinic design, and earlier this year we were fortunate enough to get the support of Colac Area Health to put in place a very similar clinic structure there. So our next little packet of seeds had arrived. Next slide. You doing slides? I'll do the next. Some key changes to the local team were that in addition to our wonderful administrator, we employed myself as coordinator who worked together seamlessly, and we were able to attract a very experienced social worker and a keen visiting psychologist who gives the team a dynamic shape. This pie chart shows how effective our intake process has been in reducing our waiting list. The large green segment shows who remained on the waiting list after the initial intake process, which is a little over half. All of the left-hand side of the chart shows the categories of patients that have been able to be removed from the waiting list for reasons such as now being out of catchment or already having connected with a private paediatrician. We did not expect such a dramatic effect on our waiting list, but I think it speaks to what many other similar services would find with their own waiting lists if they were able to be periodically reviewed. This lovely graph shows the before and after effect overall on the waiting list, which has fallen across all categories of patients after growing steadily for years prior. And if we dig a little deeper, can see that our waiting list reductions have occurred across all categories of problems or triage category. We can also show that our intake processes are also helping patients while they remain on our waiting list. This graph shows a little snapshot of the number of referrals we have made following intake to our local mental health services, Headspace, CAMS, Counselling and Collins Group, who is our visiting psychologist who runs group sessions, as well as referrals to allied health support such as speech, audiology and social work. I know some other services have considerable expertise in this, but we are pleased to see the breadth of service that can be found for our patients, even in a rural area, with our local knowledge. In Colac, we have had some really pleasing early evidence that this model addresses the hardest group. On the left, we have the breakdown of appointments in the years prior to starting the new model. The tiny green blocks show that, depressingly, we had only managed to get in 6 new learning, behavioural and developmental patients in that time. On the right, you can see that after the new clinic started, and in just 6 months, we have been able to see 53 new patients in this category, while increasing or maintaining patients in all other categories. So our prem data in Colac is just as good. And if anyone would like to see how our dashboard looks for Colac, you can follow the QR code.
You know why it's so good, right? The people are fantastic and they make this clinic work, and they lead to patients feeling like they've been really felt heard and cared for. Now, I already completely hashed poor Hannah's great presentation about her GP data over in Heritage Room 3 before. The other area of study we were able to put in place right at the start as we did this changeover was to try and map what our GPs in Colac were feeling about the clinic before it started and the clinic afterwards. And we knew that there would be a number of areas that were really interesting and important, and probably the biggest one is that GPs in general in the region lack confidence in identifying neurodevelopmental conditions. These are more than 75% of the patients that come to our clinic, and the GPs in our area don't feel they know how to identify them. They were also lacking in confidence in prescribing for these conditions. So if we're going to have successful shared care, we needed to know that in order to put in place much more prescription and prescribing support for GPs if we're going to successfully transition patients to their care. And I think that made me a little bit worried, but the great part of this data is that it shows that many of them are actually interested and expect to take on the care of their patients after they've been reviewed by us, which, if you talk to a lot of specialists, they're labouring under the misapprehension, particularly in paediatrics, that when a GP refers to them that they want them to take over the patient, and we've found that's not true. Okay, and anecdotally, it's true. We've been able to transition 14 of our patients to GP shared care in the space of a few months. It's only a small early signal, but it's very gratifying because the number used to be 0, as I said, and anything is better than 0. But actually, I think this will build quite quickly now that we've established this as possible and possibly even the norm in the region. I think over time, across our whole region, we will be normalising shared care of paediatric patients, and particularly shared care prescribing for neurodevelopmental conditions. So here's my list of takeaways. I'm not going to read them all out to you. Much of what we hoped would happen has happened. And particularly, we can see that it's actually worked even better in Colac than it has in Geelong. I think that I've been really happy that we've been able to start this process, but there's still a lot of work to do to better directly support GPs in their care of our patients and to give them confidence in managing and entering into shared care arrangements. Obviously, everything I've presented today, I've tried to present a lot of graphs and evidence because actually that's how we get change and that's how we convince our funders and our health services to adopt new models. But it's actually more interesting to me the intangible aspects of a model like this. First, assembling good teams has a really profound ripple effect. In a small place like Colac, the paediatric services were very thin, the demand was high, we had great people working in isolation, and they burnt out and they moved away, or they moved into private practice. And when we originally set up our multidisciplinary meetings, they were just for the clinic staff. We really were there to meet the NWOW requirements and have everybody sort of look through all the goals of care and do the sign-off. But actually, we've actually drawn in all these people throughout the organisation who now attend the meetings. We get mental health clinicians, dietitians, speech therapists, physios. We even had our CEO visit once, which was really nice. And when you assemble this group of similarly motivated, really clever people, it's galvanising, and it goes well beyond the immediate group. It's galvanising for the whole institution. And I believe in these rural and regional areas, we're going to keep all of us working there longer with less burnout if we've got team-based care. Can you scroll down for the next bit for me? Thank you. Secondly, I've sort of mentioned it about the waiting room, but the space between appointments and the waiting room is where the magic really happens. When you have a model of funding that is purely funding isolated patient interactions with specialists, the sort of old model, and you switch to one where you're supporting a team of allied health and administrative professionals, you suddenly have a clinic which feels available and is always actively helping. It feels like it's holding the community the whole time and everyone benefits. The patients make progress between appointments, forms get filled, services are connected, child protection is harassed into action, and we know that they're being harassed sometimes daily by our social worker, which for us is a big deal. And also complex patients, which if we're on our own, let's be honest, can be totally overwhelming and contribute to us not wanting to work. They become a shared load. They don't overwhelm the service or each individual part of the service, and they themselves feel more held, so they need less of the individuals anyway. So I think we've got the seedlings. I think we've started growing a forest. I'd really like to keep growing the whole way across, at least in my area in paediatrics, and set up similar models across the region. So thank you all for your interest, and I hope to see you all out there in the region trying to stand up your own trees.
Thanks very much, Lawrence and Jess. That's really quite inspiring and a real example for all of us to follow, I think. We've probably got a minute or two. I'm just looking across at the tech support there. We got time for one or 2 minute yep. Yeah. So anyone like to ask a question? I've been storing one up, which is a bit of a broken record of mine. And this seems to me an example of how a health service and specialists in a health service can collaborate with primary care. Do you think it's just paediatrics, or do you think it can move beyond paediatrics?
What's been really interesting is that NWOW's been around for a while. Most of us are in clinic, most specialists, I should say, are employed in clinics that are NWOW funded now. But actually very few specialists who I run into understand what is possible with NWOW funding. So they're using NWOW funding to fund old models, but actually you can do a lot more. You can be a lot more creative than you realise. And the creativity comes in being able to use that funding to draw in the right people and share the care with everybody. And that includes actually allocating funding that allows you to spend time supporting GPs or whoever's doing the primary care, allied health, whoever it might be. Yeah.
I think it's a great message there.
Yeah.
Any other questions or comments people would like to make? Okay, well, look, please join me in thanking Lawrence and Jess for a terrific talk.